Hello everyone, my name is Natalie Niehoff, and this is my scholarly project presentation. The title of my project is Video Education in Cardiac Rehab and Patient Perceived Quality of Life, a Quality Improvement Study. My committee members include my chairperson, Dr. Snell, and my community member, Dr. Kristen Golden. Background and significance. Cardiac rehab is a targeted program which seeks to improve health outcomes, exercise capacity, and quality of life of patients with cardiac and pulmonary disorders. The program is based in targeted exercise training methods and patient education on a variety of subjects, which include lifestyle modification, disease processes, medication adherence, and emergency symptom recognition, for example. Educational methods include written material and discussion with experts like pharmacists, dietitians, and diabetes educators. This project is a quality improvement project which came about through discussion with the cardiac rehab staff. There was frustration from the staff regarding the lack of reliable and up-to-date video education for patients to view. Their prior methods for playing videos in the department had been removed, and there had not been a consistent manner for playing video education in the department for about over a year. The aim of this project was to improve patient-perceived quality of life through the incorporation of updated video education in the cardiac rehab department. This was assessed by using the Dartmouth Quality of Life Index, which measures self-reported quality of life based on the following categories: pain levels, overall health, changes in health, feelings, physical fitness, social support, daily activities, and social activities. This survey is already used at the beginning and upon completion of the cardiac rehab program. It's scored from 1 to 45, with the lower the score indicating a better perceived quality of life. Review of literature revealed 3 primary topics. Education techniques were explored through various research articles and were found to be seeking engagement from patients and included various levels of participation, such as viewing, listening, and active participation in discussion. Improved health outcomes were discussed in several research articles, and patient education was found to improve patient knowledge and confidence, decrease anxiety and pain, and improve patient satisfaction. The use of virtual or video sources specifically for patient education was explored as well. Virtual and video sources were used in the home, hospital setting, and in cardiac rehab. This style of patient education was versatile and easily accessible for patients. And virtual cardiac rehab was successful with their use of video education sources. The theoretical framework that influenced this research project is the theory of plan to change from Havelock and Zlotto in 1995. This framework includes 6 steps of implementing a process change. Step 1, including building relationships, which was completed through open discussion with the cardiac rehab staff and their leadership to understand their frustrations and to begin brainstorming solutions that would work for them. Step 2 included examining and clearly defining the problem. The problem was that the staff within the cardiac rehab department did not have a reliable method for playing video education for patients, which they wanted to implement in their sessions. The third step was to acquire resources to implement the change. This involved working with staff in the cardiac rehab department to understand their schedule and topics that they teach, as well as working with the IT department at the hospital to find a way to play the videos in the department. Number 4 was to try. This included implementing the planned project schedule in the cardiac rehab department. Number 5 was to extend, which included allowing for adequate trial of the process change. The staff in the cardiac rehab department was open to change and open to implementing this new process. Finally, step 6 was to renew, which was an ongoing communication effort aimed at identifying the problems with the process or any problems that they had with the process and make corrections as needed. It also included assessing the success of the project at the end of its completion and modifying it for routine use in the department. Now I'll go ahead and discuss the methods and design of the project. This project was a quality improvement process, and it was completed through several steps. Step 1 included collecting relevant educational videos through the hospital-approved database CRAMES On Demand. This database is used within other departments to provide patient education and had not been utilized in the cardiac rehab department. Videos were selected and assigned to specific sessions based on the topics planned for discussion on those session days. Step 2 included educating staff on how to play the selected videos to the overhead televisions in the department. The videos were accessible through the database online and were played through HDMI connection. Step 3 included following the schedule for playing the selected videos in each session over an 8-week period. Step 4 involved retrospective chart review to collect the scores from the Dartmouth Quality of Life Index of patients who had completed cardiac rehab during the interventional and control period. The interventional period took place over 8 weeks, and the control period included scores from patients who had completed cardiac rehab exactly 1 year prior, who had not had updated video education. Step 5 was to perform statistical analysis comparing the pre- and post-intervention scores with the help of Dr. Powell's through the Mann-Whitney U test. After completing these 5 steps, the correlating chapters of this project were completed and results were further discussed. The project site was at a small hospital in St. Louis, Missouri, which serves rural and suburban communities. The sample size included 44 individuals. The pre-intervention had 23 patients, and the post-intervention had 21 patients. The patients included in the study met inclusion criteria, which involved the participant being over 18 years old, who had completed cardiac rehab during the intervention period and the control period, who had completed the Dartmouth Quality of Life Index after their final cardiac rehab session. Exclusion criteria included those who did not complete cardiac rehab during the pre- or post-intervention times and those who did not complete their Dartmouth Quality of Life Index. Data analysis was performed with Dr. Powell's through the use of SPSS. The Mann-Whitney U test was used to analyze the data collected for this project because the data was ordinal and included ranked responses from the Dartmouth Quality of Life Index. The Mann-Whitney U test was selected because it is used to compare 2 independent groups, and it was also selected because of the specific sample size of the participants, which was 44 patients, and also the type of data, ordinal data. The p-value for this test was 0.238, which demonstrates that there was no statistically significant difference between the pre- and post-intervention groups. The mean of the pre-intervention group was 1.65 points lower than the mean of the post-intervention group, and the median of the pre-intervention group was 1 point lower than the median of the post-intervention group. While the p-value was not statistically significant, the average score decreased after implementing the video education intervention. This slide includes a box plot for comparing pre- and post-intervention scores, and as you can see, the pre-intervention scores were slightly higher than the post-intervention scores. And as I mentioned before, The goal is to see a decrease in the Dartmouth quality of life scores because that typically indicates a better self-perceived quality of life from patients. The limitations of this project include a small sample size, which was 44 patients. Increasing the sample size would improve power, reliability, and generalizability of this study. Another limitation was the time interval for the intervention period, which was 8 weeks. I think this was too short of a time to see the true impact of the improved video education process. Spending a longer amount of time implementing the video education change would increase exposure for patients and may have had a more positive impact on the quality of life scores. So that might have improved the power of this study. This study could also be improved by implementing the intervention in a variety of communities, such as rural, urban, and suburban areas. It would also help to implement this project in a variety of regions throughout the country to have a more representative sample. The discussion of the project. This project introduced a reliable method of playing video education in the cardiac rehab department, which was a priority. Implementing this project increased conversation surrounding video education and the need for continuous review of the educational materials provided to patients in cardiac rehab. Based on the results discussed earlier, I would recommend further development of the project, including a longer implementation time, a larger sample size, and increased diversity in the location of the project to hopefully be more representative of the country as a whole. These changes would help to bring about further understanding of how video education may impact patient-perceived quality of life. The implications for practice seen through this project included creating additional learning opportunities for patients through playing consistent educational videos during cardiac rehab sessions. Research surrounding video education points to positive outcomes and improved patient experience. So it's important to incorporate reliable and evidence-based educational materials for patients to view. Implications for future research. The implications for future research include the need for media-based and video education to continue to be evaluated for its efficiency and for their relationship with patient outcomes. The goal should be to continue to improve educational techniques in order to optimize patient education and improve health outcomes. Further research could be done to understand how media-based and video education impacts other factors relating to health outcomes, such as knowledge, understanding disease processes, and patient satisfaction, for example. There's a variety of ways that this study could be adapted to further benefit patients and to further understand how certain educational interventions can best serve patients. In conclusion, the video education method was successfully implemented in the cardiac rehab department. The difference between pre- and post-intervention scores on the Dartmouth Quality of Life Index were not statistically significant. However, there was a decrease in both the mean and median scores post-intervention. With further studies, there may be a better understanding of how the video education may impact quality of life scores. However, these results could point to a positive association. There is definitely a need for continued evaluation and further research to better understand the impact of video education on self-reported quality of life. Implementing this scholarly project in pursuit of my DNP degree has helped me grow in a variety of ways that I plan to continue to take with me as I move forward as a provider. It has definitely helped me grow in critical thinking. It's helped me to critically think about the sources I'm reviewing and how previous research can help to shape and form future research. And it was definitely influential to review previous studies in relation to the intervention that I wanted to complete for this study. I also grew through persistence needed for this project. It definitely tested my patience. It tested my ability to stick with this project over the past several years. It allowed me to make connections with individuals on the IRB boards at the facility where this study was completed, as well as helping me to advocate for myself, seek help and assistance when needed, and to really stick with it to understand the full process of implementing research. I plan to take these skills with me in the future, and I hope to continue to learn about conducting research, possibly implementing future research throughout my career, now that I know how to implement the process. I really hope to take these skills with me as I serve my community, and I hope to continue to improve the lives of others around me and to seek further evidence-based practice and continue to seek to improve the lives of patients around me. Special thanks and acknowledgments to the staff and leadership in the cardiac rehab department for their continued communication and cooperation with me throughout this project. I worked closely with the leadership and the staff in the department to make sure that this process was something that they could realistically implement in their department and something that they could see benefiting their patients. Through this project, I've been in communication back and forth with the staff of the department, and they have mentioned that they're continuing to utilize the process for playing videos for patients. And so it was really neat to see how this project helped to solve a need for them and solve the problem first discussed in this presentation. Additional thanks to the Maryville University Catherine McCauley School of Nursing faculty, including my chairperson, Dr. Snell, and all of my professors throughout this program. There have been so many questions, and it's just been such a learning process. So I really appreciate their guidance and patience throughout this entire project. I really feel like I've learned and grown a lot, and I appreciate everyone's help in completing this. And then finally, I want to thank my classmates and peers for their continued feedback on my project and for just being in this boat with me. I appreciate, the continued discussion with my classmates over the last several years in implementing this project. Finally, I am open to any questions, comments. My email is listed here. If anyone would like to leave a comment or reach out to me for further questions, I'm happy to continue to chat. And the following slides include my references used for this presentation. So we have a few here. Thank you so much to everyone for listening to this project, and I really appreciate all the support throughout the last several years. Thank you so much. I hope you have a great day.